At the end of the today's lecture, BBS second year students will be able to differentiate well between benign and malignant tumors. They should also be able to discuss the laboratory processing of tissues, discuss what and how the hematoxylin and niacin staining is performed. They should know, they should identify the gross features of benign and malignant tumors, and as well as microscopic features of benign and malignant tumors. They should know how to discuss the characteristic features of anaplasia. This is the most important area of this lecture today. Then they should be able to discuss local invasion, routes of metastasis, and some of the important clinical aspects of malignant tumors. Let's begin with the recap. And the recap will show us we will be talking again about the benign and malignant tumors, how benign tumor appears, how they are well encapsulated. They are surrounding by connective tissue capsule. They are usually well differentiated. They resemble their normal counterparts, and they do not show much of the pleomorphism or much of the cellular changes in the architecture or function. While on the other hand, malignant tumors, they do not have a well-formed capsule. They are, they vary in size and shape. There is disturbed nucleocytoplasmic ratio, and obviously they have the power to invade. They have the ability to break the basement membrane, invade the basement membrane, or invade the surrounding tissue. And they can also metastasize to distant sites via different routes. So these were the features that we discussed in the last lecture. Benign tumors, they grow slowly. Malignant grow rapidly. Benign have an expansile growth, while malignant have invasive growth. Benign tumors are usually encapsulated, and malignant are not capsulated. Benign tumors do not, recurrence of the benign tumors after the surgery is rare, while malignant tumors recur quite frequently. Benign tumors do not metastasize, while malignant tumors do. Benign tumors do not kill until they compress the vital organs, while the malignant tumors can kill through cancerous process. Benign tumors do not show metastasis or rarely show metastasis, while malignant tumors show a lot of necrosis, ulceration, and a lot of distant metastasis. Most of the time, the patient dies of metastasis rather than the primary tumor. No cachexia. What is cachexia? Cachexia is a clinical term used for the patients who are cancerous, and you've seen that they have reduced appetite also, since there is a lot of protein loss due to cancer. The patient has become emaciated, very lean, thin, and loses a lot of muscles and fat of the body, and this is known as cachexia. In these patients, the malignant patients, the cancer patients also have marked anemia. So this was a recap, and now we will talk about the processing of the tissue. This is the picture of surgically removed tumor. Currently, ultrasound and CT scan may show that it is benign or not, but pathologists don't know much when he is receiving the sample in the laboratory and for the histopathology. So, for the first thing that histopathologists do is observe, and then it takes a lot of measure in all dimensions, and then the pathologist or histopathologist needs to cut it into different thin sections to be submitted into the cassettes. The cassettes are coded according to the series of the tissues that are being received in the laboratory, and we have to do a certain thickness, take a certain thickness of the tissue inside the capsule and put it inside the cassette, and the cassette has different holes for penetration of formalin. And before that, remember that a tissue that is being submitted to the laboratory or taken out of the surgical OT, it has to be dipped inside 10% formalin. And again, these are the holes for the penetration of the various chemicals that are going to be used in the processing of the tissue. Later on, when this is being processed in different concentration of alcohol and formalin, this tissue is put inside the wax. What does wax do? Wax makes it this section permanent. Also, it makes it easier to take different sections, very thin sections of this waxy tissue on microtome. This is how the thin sections are taken off, and then these thin sections are initially pasted. They are colorless, they are waxy, they are pasted on the slide. Later on, they are dipped into humus-toxylin, eosin staining, and when you take out the slide after the requirement amount of time that is needed to stain these slides, they adapt these color. And we all know that the nuclei and the proteinaceous elements will take up the purple color, and there is a basophilic color, and the hematoxylin, and the eosin is taken up by the pinkish color, or eosin is taken up by the cytoplasm. Now the next step, when it reaches, so this is all the processing taken taken care of by the technicians. The final slides that are being sent to the histopathologist, and the histopathologist put inside the microscope and watch, and he may watch it alone, or he may use a terminal to be shared with his residents or junior fellows. So staining with HNE is used as an acidic dye, as you all know. It stains the basic or acidophilic structure red or pink, and this is also sometimes called as eosinophilic. As you can see here, the pinkish stain the cytoplasm. Hematoxylin is a basic dye, and it is used to stain acidic or basophilic structure, that is deoxyribonucleic acid or ribonucleic acid found within the nuclei. Since they are acidic, so they stain the structure purplish blue, and that's why you see the nucleus to be purple blue or purplish in color. There's a nucleus stained purple by HNE staining. Coming back to the tissues, we have discussed in detail about the stratified squamous epithelium. It has 5 layers, starting from the basement membrane goes up, and it has multiple stratum basale, and then multiple layering, that is strata. The lowest one near the basement membrane is stratum basale, and then the spinosum, granulosum, lucidum, and then the topmost is corneum or keratin layer. Now, what I need to tell you is that when there is some precancerous changes that begins in the stratified squamous epithelium, it always starts from the base. It starts the cell of the stratum basale, or the basal cell, or the base. They start varying in shape and size first, and then they go upward, involve the lower third, middle 1/3, and the topmost layer. When all the 3 sections, all the thirds of the stratified squamous layer, from the basement or the basal layer to the top keratin layer, is involved, then this is known as carcinoma in situ. That is high-grade dysplasia. If it involves only lower third, it is mild dysplasia. It involves middle 2/3, it is moderate dysplasia. When it involves all the 3 layers, it is known as high-grade dysplasia or carcinoma in situ. They are interchangeable terms. So for now, you are not seeing carcinoma in situ, maybe from here to here, but now look at this area. What is happening here? These cells, which already occupied all the 3 layers of the stratified squamous epithelium, are now invading the basement membrane, and they are invading the basement membrane, crossing the basement membrane, and they are actually invading the dermis, because we know that the stratified squamous epithelium forms the epidermis. Now, since it has invaded the basement membrane, going into the dermis, it is a malignant, frank malignancy. It is an invading tumor. It is no more dysplasia. It is called invasive squamous cell carcinoma. Okay, so I was explaining to you about dysplasia. Dysplasia is nothing but a disordered growth. Remember that. And we need to understand this mechanism of dysplasia. So the story begins with stimulation. Prolonged stimulation, prolonged hyperplasia or metaplasia. By now you should know what is metaplasia. Change of one epithelium, mature epithelium type to another. So this prolonged metaplasia or hyperplasia or any kind of cell injury that is occurring within the cell can lead to low-grade dysplasia. Low-grade dysplasia is a disorderly growth. The cells begin to change their shape and size, and obviously their function also. So they are precancerous cells, but still the dysplasia is low grade. We divide the dysplasia into low grade and high grade. Now what happens? This green area of the green boxes, till this lesion, the dysplasia or any cell injury is reversible. So if it is reversible, it may turn into the normal state of the cell. It can go back to the normal state of the cell, or it may divide into a benign tumor, or it can lead to high-grade dysplasia. If it is a benign tumor, the cancer is the wrong word here. If it is a benign tumor, we know the features of the benign tumor and non-malignant tumors, right? So still the patient is safe. But as it goes to the high-grade dysplasia, this is the initial stage of the cancer. And this high-grade dysplasia, as I just explained to you, is similar to carcinoma in situ, and it remains within the basement membrane. It does not invade the basement membrane. Still, it is irreversible because it is high-grade features. Now, as soon as it invades the basement membrane, it becomes a malignant cancer or invasive cancer. And this is called late cancer. It has capability of invade the surrounding tissues and also blood vessels, and it has a capability to metastasize. Now this picture or diagram will nicely explain to you the concept of dysplasia and then invasive carcinoma. This is a normal stratified squamous epithelial layer. Let's look at the cellular morphology. There is 1:4, that is 1 part nucleus and 4 parts of cytoplasmic ratio. Coming to the mild dysplasia, the dysplasia, when you see these horizontal cells, it means the cells are in normal morphology. So you see these horizontal cells in, upper 2/3, but the lower 1/3 is involved. So when the lower 1/3 shows changes, it is called mild dysplasia. The patient and the condition of the patient is still reversible at this stage. See the basement membrane also. It is intact in most of the segment. This is the dysplasia, mild and moderate. Moderate involves, as I just told you, about middle 2/3 of the epithelium. You can also see the cellular morphology. The nuclear cytoplasmic ratio is completely disturbed, and also cellular changes in the shape and size are also visible. Coming to the severe dysplasia is the involvement of all the 3 layers. You can't see the horizontal normal cells in the top layer. So it means that it is severe dysplasia or carcinoma in situ. But here the basement membrane is not broken. As soon as the basement membrane is broken, this is wrong. Carcinoma in situ, the basement membrane has to be intact, right? So whenever there is basement membrane breaking down, and the tumorous cells or the bad cells, they start invading the dermis or invading the basement membrane, the surrounding tissue, it becomes an invasive cancer. You can also see the tumor cells morphology in this picture, which is really bad. We will discuss this morphology in detail, but try to grasp the concept right now. What is mild dysplasia, moderate dysplasia, carcinoma in situ, that is severe dysplasia, and then invasive cancer. Now this picture may show you the normal cell of tissue of the body, and this is a microphotograph, that is a microscopic depiction of this is some kind of a gland or duct or acini surrounded by almost similar morphological cells with similar morphology, uniform nuclear sizes, and lots of cytoplasm. And it is benign again here also, but you can see when it becomes cancerous, there is shape change, the borders change, the nuclear morphology change, the cytoplasm change, and this becomes malignant. And this malignant tumors, the cells have different morphology. The outer membranes are irregular. The chromatin is clump, and you can see some of the cells are bigger, some are smaller, some are ovoid. I mean, there's no uniformity in the malignant cells. Now, what is differentiation in aneuplosia? The extent to which the neoplastic cells resembles their counterpart, the normal counterpart, is known as differentiation. Parenchymal cells resemble the corresponding normal parenchymal cells, both morphologically and functionally. But if they develop lack of differentiation, that is, lack of resemblance to the normal counterpart, it is known as aneuplosia. So aneuplosia can be defined as lack of differentiation. Now, it may also be known as dedifferentiation, lack of differentiation, or aneuplosia. There are three grades of this differentiation: well differentiated, moderately differentiated, poorly differentiated. Usually we stick around these three. Well differentiated, when the tumor cells resemble or very closely resemble the normal counterpart. Moderately differentiated, when first of all, let's discuss the poorly differentiated. The poorly differentiated, they do not resemble at all with the counterpart and shows a lot of variation. So the tumor is known as poorly differentiated tumor. Now, the stage between well differentiated and poorly differentiated, some of the cell may resemble the normal counterpart, may function as of the normal counterpart. Some do not. Then it is known as moderately differentiated. There is another stage which is known as undifferentiated, and this undifferentiated stage is actually the stage of tumor when you cannot simply say that if it is a squamous cell carcinoma, of an adenocarcinoma, lymphoma, or any other cell, and you have to go for a special stain for that. That tumor is known as undifferentiated tumor. So benign tumors are usually well differentiated. This is a normal thyroid tissue, and you can see that this is thyroid adenoma. And thyroid adenoma, the cells and the follicles of the thyroid tissue exactly resemble like that of the normal thyroid tissue. So we call it a benign tumor or benign adenoma of the thyroid. This is a leiomyoma of the uterus, and this is a myometrium of the uterus. Myometrium of the uterus is composed of smooth muscle cell bundles. Similarly, leiomyoma or fibroid of a uterus, it is also composed of the benign cells of the myometrium, that is smooth muscle cell, but obviously it is bulky. It has a bigger size than the normal uterus. So it is a benign tumor, and see they resemble each other very well. Now, well-differentiated squamous cell carcinoma, as explained to you in my last lecture also. Now you must be very familiar with this lining epithelium of the stratified squamous epithelium, the basement membrane, and the dermis. What is happening here is, or the subepithelial tissue. What is happening here is that these tumor nests, they are of squamous appearance, and they form a lot of keratin also. That is, they are functioning like squamous epithelium also. But they are found within the dermis or within the subepithelial tissue. They have invaded the basement membrane. This keratin pearl formation is very important. This is the identification point of a well-differentiated squamous cell carcinoma. Grades of a tumor. The morphologic distinction between well-differentiated tumors and benign tumors may be very subtle. As you all know that well-differentiated are exactly like, benign tumors. Now, little or no evidence of differentiation. If you cannot differentiate the tumor based on its morphology, then it is known as poorly differentiated. And between well and poorly differentiated tumors lie moderately differentiated tumors. So there are three grades of tumors. Now, a very important aspect is aneuplosia. The aneuplosia or anaplastic neoplasm, lack of differentiation or aneuplosia, is a hallmark of malignancy. The term aneuplosia means to form backwards, that is a reversal of differentiation to a more primitive level. What is primitive level? An embryo. When a human was not a human but an embryo, and the cell were at a primitive level, they were not well differentiated at that time. Gradually they mature and form different organs, and the differentiation occurred. Now, in the term neoplasia, we are going towards the backside, towards the primitive stage of our existence. So lack of differentiation is known as aneuplosia. And the next important point here on this slide is that it is a hallmark of malignancy. Hallmark of malignancy is not dysplasia. Hallmark of malignancy is not metastasis. Hallmark of malignancy is not invasion. It is aneuplosia. Now, what is anaplasia? Lack of differentiation, de-differentiation. There are certain characteristic features of anaplasia that you should remember by heart and that you should understand also. So the first one is pleomorphism. Pleomorphism is variation in the shape and the size of the cell. Then abnormal nuclear morphology, the chromatin clumping, the different irregular nuclear borders, the prominent nucleoli, it is all anaplasia. Then there are frequent mitosis present in the tissue. Loss of polarity is loss of organization of the cell, as if you're seeing in the stratified squamous epithelium. The 5 layers of stratified squamous epithelium is normally identified, but when there is loss of polarity, there is disorganization, loss of organization of the tissue, the layers will not be identified. Other changes are there, and then we will be explaining in the next slide. And local invasion is another important aspect of anaplasia, and metastasis is also an aspect of anaplasia. So there are 7 points or 7 characteristic features of anaplasia. Now coming to the normal cell, as I explained to you already, that 1:4 of the nuclear cytoplasmic ratio, 1 part nucleus, 3 to 4 parts cytoplasm is a normal cell. But in a cancer cell, you will see that either it is 1:1 or 2:1, that is 2 part cytoplasm and 1 part nucleus. And then you can also see the shape and the size change in the nuclei, variably shaped nuclei with different, the color is different, the organization is different. And then you can also see that the normal cells do not divide as much as the tumorous cells, the malignant cells. You can also identify some the mitosis present over here. Also, disorganized arrangement, that is loss of polarity, is also found. They do not show well organized structure. In the normal cell, the size is constant, the shape is constant, like here. But in malignant cells, there is variation in the size and the shape of the cell. As you can notice in this picture, you can see that the cell surface is not regular, the nuclei are not regular, the chromatin is very clump and darker nuclei are present. And then although sometimes all of the normal features of the cell are lost in a malignant cell. So what is pleomorphism? I explained to you, it's a variation in size and shape of the cell. As you can see here, this is a normal ovoid, maybe normal cell, but when you compare it with these cells, when you compare it with these cells, there is variation in the shape and the size of the cell. Okay, and then there's some tumor cells may be small, some may be large. Okay, you can also find some tumor giant cells, as the arrow indicates. The tumor giant cells are actually formed by the combination of 2 or 3 or more than 2 neoplastic cells or the malignant cells. They form tumor giant cells in certain cancers. So again, a very good picture showing us from smaller size to medium size to larger size cells. You can also notice a good mitosis over here. And then you can see smaller, these are prominent nucleoli, more than 1 nucleoli also. Look at this shape and size. This is a mitosis over here. So lots of pleomorphism in this slide. Okay, coming to the cellular nuclear size variation, again you can see the pleomorphism, a lot of pleomorphism. Every cell is different in shape and size. They do not match with each other. Then they have this tripolar spindle, which is a bad sign, a bad kind of mitosis. We call it abnormal mitosis seen in cancerous cells. You can see some tumor giant cells over here also. So this is a tripolar spindle. And the nuclear hypochromasia, you can see a dark chromatin clumping, which the chromatin clumping causes darkness of the nuclei. So nuclei are large, yes, we can see that. The nuclear cytoplasmic ratio is 1:1, that is 1 part nucleus and 1 part cytoplasm. Normal ratio is 1:4, 1:6. The nuclear shape is irregular. The chromatin is coarsely clumped also. Okay, mitosis. Mitosis, the presence of mitosis does not always indicate that it is a malignant tumor. Please remember this point. But yes, in malignant tumors, we find a lot of mitosis. So just showed you a tripolar or abnormal mitosis, but besides that, some mitoses are present, which can be identified by you, but they are indicative of rapid cell growth. And we know that tumor cells multiply at a fast speed. Loss of polarity, as I just explained to you that it is polarities orientation, that is all these squamous lining epithelium or any other epithelium, they have the particular orientation. But when it is a tumor, these cells lose their orientation. They do not form layers and multiple layering, or they do not resemble their normal counterparts. So sheaths and large or large mass of tumor cells grow in disorganized fashion, and this disorganization is known as loss of polarity. So again, you can see in one picture stratified squamous epithelium with all its normal lining layers and linings, and in the other half of this right side of the picture, you can see that there is disorganized growth with lack of organization or orientation. Now, coming to the important features, the clinical features of this, neoplasia or malignant tumors, some of them show a paraneoplastic syndrome. What is a paraneoplastic syndrome? Abnormal amount of hormones are being produced by these tumor cells. They actually grab the characteristic of endocrine cells. They release, they become endocrine organs, and the organs will secrete hormones, and then this is how they produce a crisis, an endocrine crisis in the body, and this crisis is known as paraneoplastic syndrome. For example, bronchogenic carcinoma or lung carcinoma, certain type of lung carcinoma may produce corticotropin, that is ACTH, parathyroid-like hormone PTH, insulin, glucagon, and other hormones giving rise to. Obviously, you can understand that limitless properties or secretion of these hormones can produce a detrimental effect on the body or the organs of the patient, and it is very difficult to manage them clinically. Also, you will have a separate lecture on paraneoplastic syndrome and clinical features of the neoplasia, so we will just not go into the detail of it right now. Now, coming to the difference between metaplasia and dysplasia, this is one question that we ask you a lot. So metaplasia is nothing but replacement of one type of cell with another type of epithelium or cell, and it is associated with certain tissue damage or repair and regeneration. And it is actually replacing cell type is better suited. The replacing cell type, that is a new cell type, is better suited to that particular environment. For example, in smoker, as you know, that the respiratory epithelium is transformed into stratified squamous epithelium. Now, what is dysplasia? Dysplasia is a disordered growth. It occurs in epithelia. It does not occur in parenchymatous, mesenchymal tissues. And then you can see that changes include loss in the uniformity and loss in the architectural orientation, as we just discussed in detail through the pictures. And dysplasia, the cells show a lot of pleomorphism, yes. And then they may contain also large hyperchromatic nuclei with high nuclear to cytoplasmic ratio. So this is metaplasia, changing of one epithelium to the normal, stratified squamous epithelium. Columnar epithelium is changing into stratified squamous epithelium at the junction of esophagus, where we call it esophagus. Now, dysplasia is completely different. It has a disorganized pattern of growth. It has nuclear pleomorphism, a lot of hyperchromasia, and altered nuclear cytoplasmic ratio. What is carcinoma in situ? I've already discussed it with you. When dysplasia involves the full thickness of the epithelium but does not penetrate the basement membrane, it is considered pre-invasive neoplasm. It's referred to as carcinoma in situ. Once the tumor cells breach the basement membrane, the tumor is said to be invasive. Okay, so dysplasia does not always progress to cancer. We have seen that in the initial stages of the low grade of dysplasia are reversible. Mild to moderate dysplasia may be completely reversible. So local invasion, what's local invasion? The growth of cancers accompanied by progressive infiltration invasion and destruction of the surrounding tissues. Benign tumors grow as cohesive expansile masses. They remain localized. They do not infiltrate, invade, or metastasize to distant sites. Encapsulation is very important for a surgeon to remove that particular tumor. Ask them, and they will tell you that if a capsule is deficient, they are always suspicious of complete removal of that particular growth. So encapsulation is the feature of benign tumor mostly. It makes the tumor discrete. It makes the tumor palpable on examination. It also makes the tumor movable. Usually malignant tumors, since they do not have a good capsule, they are fixed to the tissues. You know, when you palpate the tumorous swelling, they do not move. And then this capsule makes the surgical removal of the tumor quite easy. Now this is a capsule. As you can see, this is a tumor, and it has a capsule, a fibrous capsule. This is a fibroadenoma of the breast, and this is the breast tissue, or the a tumorous tissue. But see the fibrous capsule that is being surrounded. This tumor is being surrounded. This is a benign tumor of the breast, and it is surrounded by a fibrous capsule. So this is a microscopic depiction of the capsule. Invasiveness, the most reliable feature that differentiates cancer from benign tumor. Very important point. Okay, invasion and malignancy. You can see this is the normal tissue and this is the tumor. Now see how it invades. It invades into the surrounding tissue. This is the best picture that I would say to understand invasion of malignant tumor. They push along a broad front into adjacent normal tissues and complete local excision. Now imagine that a surgeon is removing this tumor. Sometimes, since it's not capsulated, the surgeon has to take out the bigger chunk, and even if he or she takes out the bigger chunk, some of the tissue from here, or from this corner remains behind. And when the tumor, or malignant tumor especially, remains behind, it recurs, it metastasizes, it can invade, it can grow on and on. So the surgery in malignancy is very, very critical. So what is metastasis? Spread of a tumor to a site distant from the primary tumor. Okay, so it marks as a tumor as a malignant. That is, say for example, the person is having the cancer of a colon, and the metastatic nodules are found in the liver. Then it is known as metastasis, because the primary was in the colon and then the secondary was found in the liver. So it is known as metastasis. It marks the tumor as malignant. If you find a report in which it says that there are metastatic nodules in the liver or the lung, then you don't have to think that it is a benign tumor. It is for sure a malignant tumor. Now, benign neoplasm do not metastasize. We have read it multiple times. Invasiveness of cancer permits them to penetrate. Now, what happens? How do metastases occur? These cells, the tumorous cells or the malignant cells, they invade the blood vessels, they invade the lymphatics, they invade the body cavities, and this is how they spread throughout the body. We will see now it in detail. So metastasis is all the malignant tumors can metastasize, yes. Some malignant tumors, this is makes up a good question of exam also. Some malignant tumors infrequently metastasize. That is, they rarely metastasize. And what should be coming into your mind? The name of two tumors should come to your mind which infrequently or very less metastasize, less commonly metastasize. These are basal cell carcinoma of the skin and glioma, that is a tumor of the brain. They invade but do not metastasize. Metastatic spread strongly reduces the possibility of cure. Yes, we know that if a tumor has already been metastasized to different parts of the body, then it is very difficult to cure that tumor. Pathways of spread. Dissemination of cancers may occur through one of these three pathways. Either there will be a direct seeding of the body cavities. We all know that there are different cavities in the body, like pleural cavity, peritoneal cavity, pericardial cavity. So many cavities. So tumor can get access to those cavities and spread because they have got a free area to spread them. The number two is very common spread is lymphatic spread. They invade into the lymphatics, reach to the lymph nodes, and spread throughout the body. And then the third one is the hematogenous spread, that is through the blood vessels. Now, what is an iatrogenic spread? Iatrogenic spread is how I can explain to you that if a surgeon is doing a surgery and he cuts or he or she cuts the surgical the tumor area with a surgical instrument, and then with some of the tumor cells, they are usually sticky cells. When they stick to the instrument, and that surgeon that uses the instrument on different parts of that open cavity, that the tumor cells may invade the body through that surgical instrument to different parts of the body. This is known as iatrogenic spread. That is because of the fault of a doctor. And it is the reason, for example, why biopsy of testicular masses are never done. We don't do biopsy of certain tissues. And one of that area is testis of male, because more chances of iatrogenic spread occurs. And then next is coming back to the iatrogenic spread. As I explained to you, that it may occur or spread, the tumor, malignant tumor may spread because of the fault of a surgeon or a doctor, and especially while taking small biopsies, this can happen, and this kind of spread is known as iatrogenic spread. Coming to the seeding of body cavities and surfaces, colon carcinoma invading pericolonic adipose tissue. This is one of the examples in this picture. As you can see that the seeding of body cavities can occur via this is a body cavity. As you can see, lots of fatty tissue that can be seen over here, and then you can see that these are the tumor cells which are actually invading this surrounding tissue outside this colonic wall. This is the colon wall, ends over here, muscularis externa and serosa, and after that this is the extra colonic fat or the peritoneal fat, in which you can see a lot of tumor deposits. These are the purplish tumor deposits which are found in the adipose tissue. So these are the seeding of body cavities and surfaces. Again, one of the gross pictures showing you these tumor deposits within the peritoneum, and this may be coming from the colonic tissue. So most often involved in the peritoneal cavity, any other cavity, that is pleural, pericardial, subarachnoid, and joint spaces. So any of the body cavity can be involved. Subarachnoid is in the brain. Joint spaces are found all over the body. So a lot of chances of seeding of these tumor cells within these cavities. One has to be really careful when a person or a doctor or physician is dealing with malignant tumors. Coming to the lymphatic spread, lymphatic spread can be transported through the lymphatics, is the most common pathway for the carcinomas. That is, please remember that most of the carcinomas, we discussed the discriminating points between carcinomas and sarcomas in the last lecture. Please refer to that. The carcinomas are the malignant tumors of the epithelial region, and they actually disseminate through the lymphatics. And then the sarcomas are actually from the mesenchymal tissue, and they spread preferably through the hematogenous route or the blood vessels. Now, what is the sentinel lymph node? To understand the lymphatic spread of a tumor, the sentinel lymph node is actually the primary, is the first lymph node which receives the lymphatic supply of or drainage of from that tumor. That is the nearest or the first tumor, nearest to the first lymph node that is receiving the lymphatics from the primary tumor. To the drainage from the primary tumor of that lymphatic. So this is the first node in whole of the pathway, and this is known as sentinel node. So these are the lymphatic vessels, these are the lymph nodes, and the first node that receives the drainage of the primary tumor site is sentinel lymph node. The first node in the regional lymphatic basin that receives lymph flow from the primary tumor, called sentinel lymph node. Now, what is hematogenous spread? It is particular or typical of sarcomas. But when you see the typical of sarcomas, it is also seen with carcinomas, and it is not necessarily associated with sarcomas. Some of the carcinoma also adopt hematogenous route to spread throughout the body. They usually involve the veins, because veins are thin walled as compared to the arterial wall. So veins are easily penetrable. So hematogenous routes prefer using veins for their spread. Now, coming to the liver and the lungs, the liver and the lungs are most frequently involved. And this is a liver, and you can see this tumor deposits. And this is all secondary metastasis. They are not the primary. But since all the portal area drainage flows to the liver, there are more chances of liver to be involved in different kind of tumors. So these are actually the metastatic nodes that are found in the liver. Some important points to remember regarding the metastasis of the cancerous cells. The cancer arising in the close proximity to vertebral column. They actually embolize through the they involve the paravertebral plexus. And the vertebral metastasis of carcinoma of the thyroid and vertebral metastasis of carcinoma of the thyroid and prostate. Vertebral metastasis of carcinomas of thyroid from the thyroid and from the prostate is very common. Now the other tumors are the tumor which have propensity to involve the veins. These are renal cell carcinoma that is coming from the kidneys. The root is that they first involve the renal vein, which leads to inferior vena cava, and inferior vena cava drains into the right side of the heart. The next tumor or carcinoma that commonly use the hematogenous route is hepatocellular carcinoma. Hepatocellular carcinoma is a tumor that is arising from the liver. It uses the portal vein, and then through the portal vein, it may spread, widespread into the body. Breast carcinoma, they preferably they spread to the bone. Bronchogenic or the lung carcinoma, they usually tend to spread to the adrenal glands and the brain. Neuroblastoma prefers metastasis to the liver and bones. But these are not the fixed spots of metastasis or sites of metastasis in these particular tumors. They can spread to anywhere in the body. So, last but not the least, we're here to summarize this lecture. The points which we discussed a lot today and even the previous lecture were the difference between benign and malignant tumors, differentiation, anaplasia. They are well differentiated, they're malignant. The well differentiated are structures, they resemble their normal counterpart, while malignant tumors do not. And then you can see some lack of differentiation. Yes, we know what is anaplasia. It is dedifferentiation in the structure, shape, size of the cell, and it is a hallmark of malignancy. Rate of growth is, we know that benign tumors slowly progress, and the mitotic figures are rare, while in malignancy you see a lot of mitotic figures, and it has a very rapid growth. Local invasion, they form benign tumors form expansile masses, but malignant tumors, they actually do not form much of the masses. Rather, they would love to invade the surrounding tissue. They love to infiltrate the surrounding tissue, and then they sometimes may be misleading. They actually prefer to routes of metastasis like lymphatics or hematogenous routes or body cavities. Again, in the benign, you can see metastasis is completely absent. So this was the whole of the summary that what we did today. And if still I ask you that if you have any query in understanding the mechanism of neoplasia, any difficulty in understanding anaplasia and their features, levels of dysplasia, how and when it is reversible, when it is not, how it can lead, why dysplasia is a precancerous state, how it can lead to invasion and then it becomes a malignant tumor. So many things and so many new things for you, I know. So please do not hesitate to ask questions, write down your questions, and give me your feedback, solve the quiz. I've given you the date of a due date of that quiz. It's very simple quiz. If you go through these two lectures, you will find them very easy to solve, and I hope that you will understand nicely.